Κυρίες και κύριοι συνάδελφοι, θα κάνουμε μία μικρή αλλαγή στο πρόγραμμα. Ο καθηγητής, ο Brian Olshansky, επειδή δεν μπορεί να περιμένει, θα παρουσιάσει τώρα την ομιλία του και μετά θα συνεχίσουμε κανονικά με το session για το training. Με τον συμπρόεδρό μου, μάλλον τον πρόεδρο του κύριο Θοδωράκη, τον παλιό μου φίλο και συνεργάτη και δάσκαλο, ο οποίος επίσης πρέπει να φύγει σε λιγάκι. Θα προχωρήσουμε.
Εγώ 7,5 ώρα πρέπει να φύγω. So we have to present the Professor Olshansky from the United States. He's going to speak about what's the relationship between atrial fibrillation, hospitalization, and death. Can't get out of this world alive. Dr. Olshansky is on the video.
Yeah.
So you can come now.
Good morning, Brian.
Good morning. It's a pleasure to participate with you, and I'm sorry I'm not there.
Yes, as well, but how is the weather in Iowa?
Beautiful. Right now it's beautiful here. It's very nice, a beautiful morning in the fall. And
What about the viruses?
The virus is a problem, more and more problem. I don't know why. I think, this is a very difficult topic, and I wish I had the answer, but how is it in Greece?
It's getting worse.
Oh,
It's getting worse.
Oh, that's no good, no good.
Yeah. Everybody's out, so, contaminate each other. But anyway, we'll go through that. So I'm with Dr. Theodorakis, one of probably the oldest electrophysiologists in Greece. He put the first transvenous ICD and did the first ablation in Greece.
Oh, fantastic. Fantastic.
I did it in the United States, I remember, some years ago.
Well, yeah, and I met you, and it was great to meet you. And one of my fellows has been in practice in Greece for many years, Kostas Gatzoilis, in Athens.
Yeah, he was this morning with us. He's a very good friend of ours. But
good. He's very nice, very nice.
Okay, so Brian, the time is yours. We're waiting for your talk.
Well, I appreciate the opportunity. So, ladies and gentlemen, and Chairman, I'm going to talk today about the relationship between atrial fibrillation, hospitalization, and death. And we'll get back to this concept of can't get out of this world alive in a little bit. Here are my disclosures, not directly related to the topic. So let's start off with just a question. What is atrial fibrillation? And it's been called many things. It's been called a growing epidemic. Is it really an epidemic? And I will tell you that I review many manuscripts regarding atrial fibrillation, and every single one of them almost begins with the following. Atrial fibrillation is the most common arrhythmia. Now, maybe it's true or maybe it's not true, but this is what atrial fibrillation is. Now, when we look at the outcomes, we look at some of the older data, we can look at the AFFIRM trial and see that rate control and rhythm control show similar results. And yet, as you have heard this morning, and you will continue to for good reason, that there are new treatments for atrial fibrillation, including ablation, that can improve certain outcomes. But maybe the outcome of mortality is not the actual outcome we should be looking at. Maybe it's the wrong endpoint. So when you talk to a patient, there are various points of view, but patients value physical function, health-related quality of life, symptom severity, cognitive function, etc. These are important to patients and important outcomes when we address issues regarding atrial fibrillation. And that can be improved, for example, with ablation. Now, atrial fibrillation is a problem. We know this. We know that there are a variety of outcome measures that are important. And I just listed a couple here, and I want to point out a couple of things. First is that there can be an association of these outcomes with atrial fibrillation, which is fairly clear in most cases, such as the presence of ischemia, heart failure, stroke, hospitalization, various costs, and even mortality has been associated with atrial fibrillation. And on the other hand, there may be a causation of atrial fibrillation leading to these particular outcome measures, such as symptoms or quality of life, heart failure, stroke, hospitalization, and cost. But does atrial fibrillation actually cause death? And that becomes a critical issue. It's not just associated, but does it actually cause death? So because of this, there's been an international consortium of healthcare outcomes that have been developed to look at the outcome measures for atrial fibrillation and determine which ones are important and how these may be related. At this point, it's not really clear that we have a good consensus as to the most important outcome measure and what we can do to interfere with that outcome measure and improve patients' outcomes, whether it be through improvement in quality of life, improvement in survival, improvement in hospitalization, or something else. These are all important outcome measures, and they may be interrelated and they may not. And that's part of what this talk is about today. So we have to consider this relationship and these various surrogate endpoints. And for example, does hospitalization for atrial fibrillation lead to death? Well, whatever we do in terms of looking at these various outcome measures, we need to look at a reliable substitute endpoint supported by a clear mechanistic rationale. If the original endpoint requires extended time to achieve, but you would like to find a way to prevent it somehow from happening. But this surrogate endpoint must be accurate, robust, and specific for what you're looking at. So the question then becomes, is hospitalization a surrogate marker of death in patients with atrial fibrillation? Now, in terms of trying to address this question, Alak and colleagues looked at the RELY trial. These were all patients that had atrial fibrillation, paroxysmal and persistent. And it's a fairly large population. And notice, about 40% of the patients in this population over a mean follow-up of 2 years were hospitalized for some reason. And it turns out that those that were hospitalized had a greater risk of post-discharge death. In other words, 9.1% of those who were hospitalized died versus 2.2% with atrial fibrillation who were not hospitalized, with a very high hazard ratio and a highly significant result. When you looked at these data, you could not only associate hospitalization with death, but hospitalization was also associated with sudden cardiac death, with stroke, and with bleeding. And the authors therefore stated that hospitalization may serve as a surrogate for all-cause mortality in this population. Now, the point of this talk is not only related to this concept of a surrogate marker in atrial fibrillation and the relationship between hospitalization and mortality, but the critical issue here is in cardiology, as we think about endpoints, do they relate to an important endpoint? Let's think about it from heart failure. When we think about heart failure, we often think about the endpoint with defibrillators as heart failure, hospitalization, and death. But a heart failure hospitalization isn't necessarily death, and it doesn't necessarily lead to death in the heart failure population. It may and it may not. But this is a critical issue about surrogate markers. So why do you hospitalize patients? Well, at least when it comes to my practice, I hospitalize patients because they're sick, regardless if they have atrial fibrillation. And, of course, sicker people are more likely to die. And in fact, hospitalization may improve or stabilize the serious problem and extend life. So just having a hospitalization doesn't mean you're going to die. And when you think about predictors of death, well, hospitalization can be followed by death, but again, any predictor of death has to be causal, time-dependent, and robust. And if I were to ask you, and I'll tell you my answer, but maybe you have a different one, when we think about what predicts death, I'll tell you what I think predicts death. I think life predicts death. I mean, we're all going to die at some point in time. And the real issue is, well, what's the relationship in time between the thing we're looking at and the death itself? Because I can tell you, everybody with atrial fibrillation is going to die at some point, and everybody without atrial fibrillation is also going to die at some point. So hospitalization has to be a specific marker. But it turns out in this study, it was neither specific, sensitive, or robust, as 40% of the people were hospitalized, and yet few died. And death was not shown to be due to atrial fibrillation. So is hospitalization a robust marker for death? Well, it turns out that Well, any hospitalization was associated with a greater risk for dying. That is, the absolute event rate in this study was 9%, but 91% did not die. Now, while that number is greater than the 2% who are not hospitalized, it is not a very robust marker. And therefore, I think there are concerns and dangers about using hospitalization as a surrogate, because then you're going to say, well, anyone who's hospitalized needs to get more aggressive treatment to prevent the death that was going to occur, but only 9% of the patients died, where 91% did just fine, at least in the time that we looked at it, or they looked at it, actually. So the other issue is, what does atrial fibrillation have to do with hospitalization or death? Well, it may have nothing to do with hospitalization. In this study, they didn't show that it had anything to do with hospitalization. All the patients had atrial fibrillation. So atrial fibrillation may also have nothing to do with the death. It just may be an associate. And only 13% of the patients that had hospitalization for atrial fibrillation-related issues. The other thing they tried to do is correct for comorbidities. Well, I don't know if you really can correct for them. I mean, the sicker the patient, the more likely the admission. Now, if you say, well, the people with diabetes and hypertension and history of stroke were more likely to be hospitalized and more likely to die, well, okay. If you could figure that out, then you wouldn't even have to worry. You could do this a priori. You wouldn't even have to wait for the hospitalization to predict the mortality. You could do that by the predictors that are already there, the sickness of the patient. It turns out that the sickness of the patient, that is by specific parameters such as diabetes and hypertension, did not predict hospitalization. But we do know that they do predict death. So we don't really know what would predict hospitalization. I know it can predict hospitalization. That is, if you're sick, you're going to be hospitalized. And if you're sick, you're more likely to die. Now, why you're sick? It could be many different reasons that you could be sick. And you can't predict necessarily when somebody's going to be sick. The other issue is to look at the time from hospitalization to death. If the hospitalization were associated with or followed immediately by death, well, then the hospitalization had no use whatsoever. And I would agree, hospitalization is bad. No reason to hospitalize the patient if you're going to send them home and then the next day they drop dead. That makes absolutely no sense. But if the time between hospitalization and death were very long, then very possibly the hospitalization actually helped the patient and extended their life for that period of time and did not hurt, and therefore was not predictive, and therefore the association makes no sense. So what is that time prediction that's important? Well, we really don't know. Is it a year? Is it 2 years? We don't really have a value. And this study didn't give us a value of when the relationship is important and when that relationship is not important. So when it comes to the relationship of time to death, this is critical. And hospitalization did not predict when death would occur. Now, I wanted to quote an old blues song from the United States. And in that blues song, it goes like this. And it's about a person who drinks ethanol. And it says, "The doctor said it would kill me, but he didn't say when." Well, that's very much the same as here. You know, the patient is going to be sick, but we don't know when he's going to die. I mean, if that's the case, if you can't tell with a good level of security when that period of time is going to be, then it really is valueless to say that there's an association and not necessarily a causation. You could also say that an economic burden from hospitalization is important. Well, what's the alternative? Not to hospitalize a sick patient? Allow the patient to die? Of course, I would change the statistics. And what kind of study would you do to randomize a sick patient? Hospitalize some of them and not hospitalize the others and see who does better? That also is somewhat of an unusual kind of a study. But an alternative solution would be, since older patients and those with more comorbidities are likely to be hospitalized and die sooner than later, one solution from an economic standpoint would be to encourage an earlier death by some undefined means. Because after all, it could save costs and banish needless suffering for that matter. Well, I do not encourage this solution because I actually think hospitalization can actually be worth it under certain circumstances and help patients. So when it comes to the conclusions from Malak and colleagues, this is what they said. These findings emphasize the importance of preventing hospitalization among atrial fibrillation patients and adequate surveillance post-discharge. These findings may support the use of hospitalization and/or cardiovascular hospitalization as surrogate outcomes in future 8F studies. Well, I actually do not agree with this. And I think that the correct outcome in atrial fibrillation, first of all, is debatable. And I think there are many outcomes that are important to recognize. How they're related, that may be important. There may be causation. But first, we need to figure out what those endpoints are, which the critical endpoints are. And then we need to figure out the causation before we can start associating endpoints together, because surrogate endpoints are poor predictors in atrial fibrillation. But if considered, they have to be robust and causal. Hospitalization indicates sickness and thus predicts death, whether there is atrial fibrillation or not. And hospitalization for atrial fibrillation is a poor surrogate marker for death. So again, any predictor of death must consider its time dependence. I'd like to point out that we all die. I already mentioned that, and I think we all know that. Now, Hank Williams was a country singer in the United States. He died at age 29, and he died with a hit song on the radio, and this was the lyrics of the song. No matter how much I struggle and strive, I will never get out of this world alive. It was a #1 hit in 1953, and he died in Oak Hill, West Virginia, in the back of a Cadillac convertible car while this was being aired on the radio. And you know what? He had the temerity to die without even being hospitalized. So, thinking about atrial fibrillation, I think we need to focus on the important outcomes. And we need to avoid unsubstantiated hyperbole. In other words, trying to create fear in our patients and our fellow colleagues about, well, if we don't, if someone's hospitalized, everybody's got to be evaluated for something, that this is a major epidemic that we all got to treat to prevent death in everybody, that everything is all about atrial fibrillation is the most common arrhythmia. It is important, no question about it, absolutely. But we need to figure out what are these endpoints that are critical and then treat patients with that in mind. We need to be able to differentiate association from causation and consider how surrogate endpoints are related. And I think this has more of a generalized impact as well, because I think surrogate markers are often emphasized in cardiology, and they should be viewed critically and used cautiously. Surrogate markers have possible value if early identification could allow a low risk but high benefit intervention to change the trajectory of life for that patient or any other important endpoint. Otherwise, surrogates may simply magnify potential importance of a condition without really providing benefit. Thank you very much.
Brian, excellent talk. And now in Greece, it's late evening, and we're very tired, but this was a very refreshing talk. And also a new way of looking into things. First of all, my comment for Hank dying at the age of 29, probably he didn't have any AF, so there was no
I agree. If he lived longer, he probably would have had it. And it would have predicted his death.
I wanted to ask you, what's the main mechanism of death in such patients with atrial fibrillation? You think rapid atrial fibrillation promotes ventricular fibrillation, strokes participate in the mortality? What comment can you do?
Well, thank you very much for that question, because I actually think we need to do, and I think if there are enthusiastic people in the audience that would like to look into this, it's a fantastic question, and we should figure this out. I mean, we could do this with a registry and try to collect information about atrial fibrillation patients, looking at comorbidities and looking at the cause of death. No doubt, some people with atrial fibrillation do die of very rapid rates, and some die of heart failure, some die of stroke, some die of other unassociated causes, whether it be pneumonia, COVID, or anything else. But I think what we really need to know is what that relationship is. Which can we interfere with and interact with so we can reduce those risks. I mean, for example, we can control rate in atrial fibrillation. We can, in some cases, keep people in sinus rhythm. And all of these things can be very helpful for select patients. But there must be multiple things that are going on here. And we really should look at the critical issues and how much we can really make a difference. Because the other issue is, if we slow the rate in atrial fibrillation and prevent the death from rapid rates or from heart failure, the patient may die from another cause a couple of days later. So somehow we have to be able to look at this in a very careful way. But I think it's a great question, and I'd be very happy to collaborate on something like this. But this is just good food for trying to develop new studies to understand the outcome measures in atrial fibrillation better.
Thank you very much. One of my colleagues, Dr. Lefteriodis, who is from Athens, wants to ask you something.
Okay. Hi.
Okay, I don't know whether I'm clearly heard. Thank you for your excellent talk. My consideration is whether AFib still remains a vague and cloudy prognostic marker, and perhaps for some patients it could be considered as an atrial myocarditis, or perhaps the result of a serious underlying abnormal substrate, and this is a factor of serious prognosis. And for some other patients, it could be considered as a marker of aging, like early appearance of white hair. And for this population, the prognosis is excellent.
Right, I agree with you, and I guess, and as you're asking the question, and your comments are great. It really raises many issues, because I think there's an interaction between age, comorbidities, and outcome in atrial fibrillation. So some may have a myocarditis of some sort, some kind of an atrial myopathy, and how these are related to outcome measures of death or other comorbidities, we don't really know. I think it's a complex, it's going to be a complex analysis to try to figure all of this out and then determine what kind of testing would make the most sense, with the onset. Someone, for example, who's aged 30 years of age with atrial fibrillation and a normal heart probably has a different trajectory of mortality than, an 85-year-old who has rate-controlled atrial fibrillation but has congestive heart failure and diabetes in terms of the independent predictiveness of the atrial fibrillation, and compared to somebody with the same comorbidities but without atrial fibrillation. So it's a complex model, and I think this could also be worked into, some very interesting studies, and probably important to determine what kind of assessment tools are really predictive of outcome, and what should we be using for which patients. I think this is something that is kind of the next step in some of the assessment of atrial fibrillation.
Thank you.
Thank you very much.
Yeah. And I think most of us now are considering that atrial fibrillation is just part of a disease. It's another symptom, I would say. And you have to look into the patient with all the relative comorbidities, yes. And I'm glad we started moving from the isolated incident of the arrhythmia and looking into the surrogate.
I think that's exactly right. I mean, I think this is important to consider for any studies going forward, because when the Cabana study started with and with the mortality as an endpoint, it made me wonder, because I mean there are lots of good endpoints in atrial fibrillation to consider. Very important things about atrial fibrillation. Symptoms are critically important. There are many other issues that are critically important, but to change the trajectory of total mortality, I think, is very hard considering everything else that's going on with the patient. So we need to figure out a better way of looking at this. With the AFFIRM trial not showing a benefit with rate versus rhythm, of course, that's medications, and it's an old study. Nevertheless, I think it raises questions about how we should look at atrial fibrillation and what we should be looking at the endpoints, in terms of our treatment. I don't talk to my patients about, doing an ablation to save their life. I do it to help their symptoms and maybe other outcomes. But we need to look when we look at the studies that we're doing in the future, how these different issues for each patient are important, and then look at the entire patient, not just the atrial fibrillation, but the entire patient.
I totally agree. Any other comments or questions? Okay, thank you very much, Brian.
Thank you very much. I appreciate it. Hopefully next time I'll be there.
And hope to see you next year without a mask.
Okay.
Okay.
Bye.
Thank you.
Bye.
Take care.
Bye.
Take care. Bye-bye.